Hello, my name is Nadine Shelaby, and I'm a psychiatrist working out of a psychiatric hospital that specializes in a variety of mental health disorders. I have worked here for many years and typically work with patients in their late teens to early 50s. I received my PhD in psychiatry and have been practicing ever since. In a given year, bipolar disorder affects 2.6% of Americans ages 18 or older. Being a neurological disorder that affects cognitive function, bipolar disorder can range from high energy mania to low energy depression. In some cases, a patient may only experience one of the two. Manic and hypomanic symptoms include abnormally upbeat, loud rapid movements, exaggerated sense of euphoria, hyperactive, unusually talkative, hypersexuality, and poor decision making. Major depressive symptoms include feelings of worthlessness, loss of interest and pleasure, excessive weight loss without dieting, lack of ability to concentrate, insomnia, as well as thoughts of suicide. For treatment, I commonly prescribe medication as well as behavioral therapy. Neuroleptic drugs, also known as antipsychotics, are effective in acute mania cases. This drug is not a long-term treatment due to the risk of tardive dyskinesia. Other medications that are very effective in more mild cases of mania include lithium, valproate, and carbamazepine. These drugs work slower than most antipsychotics, therefore are not appropriate for acute cases. As bipolar depression medication goes, tricyclic antidepressants, selective serotonin reuptake inhibitors, and monoamine oxidase inhibitors are the most commonly used medications. Aside from medication, I also prescribe a well-balanced sleep schedule to my patients. Research has shown that sleep disturbance can trigger manic or depressive episodes. In terms of behavioral therapy, I recommend my patients to begin any of the following types of therapy: interpersonal and social rhythm therapy, ISRT, cognitive behavioral therapy, CBT, and family focused therapy. Each of these therapies allows the patient to learn their disorder as well as how to manage it. ISRT will help the patient create a routine that aids their ability to manage their mood. CBT will allow the patient to identify what triggers their behaviors and how to change negative thoughts and behaviors into positive ones. Family-focused therapy is exactly as it sounds: family support and communication to help the patient's family understand the disorder as well as the warning signs of any specific mood swings. Treatment for bipolar disorder can take anywhere from 6 months to 6 years. The effectiveness of the treatment relies on the patient's ability to consistently take their medication as well as attend therapy sessions. Typically, the more severe cases, the longer the treatment. Jennifer, not the real name of the patient, is a 37-year-old Caucasian woman who is married with 3 children. She falls under the higher class socioeconomic scale and is well educated. She has a long history of both manic and depressive episodes. Jennifer was diagnosed with bipolar disorder at the age of 19 and has been undergoing treatment ever since. Review of previous and current symptoms indicates she has had multiple episodes of depression beginning in her late teens, but that clear hypomanic episodes later emerged around the age of 26. Her elevated interpersonal conflict, hypersexuality, and excessive spending during her hypomanic episodes led to the diagnosis of her bipolar disorder. Jennifer notes that she is having marital issues and that she feels alienated from her family. She has been taking mood stabilizers such as antidepressants as well as attending cognitive behavioral therapy for the last year, but continues to have medium-level symptoms of depression. Jennifer has gone off her medication multiple times in the past, but currently complains that she is tired of being in trouble all the time and wants to try individual psychotherapy and family-focused therapy. Jennifer will remain on the antidepressants but will begin taking antipsychotics to help manage her manic episodes. My recommendation for education about the issue on a larger scale is to continue research on the why of bipolar disorder. I believe that there is a cognitive explanation as to why some patients respond to certain types of medications or therapies and others don't. I also recommend we as professionals in the psychiatry field figure out a way to make bipolar disorder more manageable without prescribing too many medications. Although research shows medication is the most effective way to treat bipolar disorder, currently it only treats the symptoms of this disorder, not the disorder itself. It is essential that other health professionals treating patients with bipolar disorder look deeper than symptoms on the surface, especially in young adults. In today's society, having a moment of sadness is often classified as being depressed. Before prescribing antidepressants, a full evaluation of the patient's cognitive and social behaviors should take place. Same goes for manic episodes and behaviors. The major problem that needs to be solved regarding bipolar disorder is finding more effective methods of treatment that minimize symptoms without causing too much unstableness in a patient's daily life. Thank you.